patient representative and the PALB2 carrier, like many of you on the call today. So I'm very pleased that we were able to set up a session like this. I think it's the first of its kind in the UK, and bring the community or group of PALB2 carriers and the families together to be able to answer many of your questions. So from my own experience, I was diagnosed with breast cancer in January 2019 and undergone 10 months of treatment, chemotherapy, big operation, radiotherapy, and I'm on letrozole and various other medications. I also had BSO, which is a oophorectomy this summer. When I was diagnosed, I had a discussion with my medical team, actually around genetic testing, as I have a family history. My father passed away from cancer when he was 50, and his mom as well from breast cancer. So clearly I had a case for genetic testing. And I remember sitting in the office of my breast surgeon when he was giving me options on testing, whether it's just BRCA1, BRCA2, or would I like a panel of 24 genes. And I of course said, let's test everything that's out there. And I came back with PALB2, and I've never heard of PALB2. So was my breast surgeon. Of course, he did hear about that, about the gene and mutation, but that didn't have much information. So it was almost left up to me to try to find more. As you all know, you go to Google, you search, you find, you go on Facebook, you go everywhere. Luckily, I was very happy to find PALB2 Interest Group and got signed up for the research and spoken to Marc. So I was very lucky to be able to get straight to the source of, and also be under the care of the guys HPOC clinic with where Anju and Vishakha from, to get all the other extra support that I needed. I think my sticking points with the gene were just basic information, particularly information about the risks for myself, trying to find some answers on why did I get the gene and my kind of risk factors for any other cancers, and how does it influence this my treatment that I was undergoing. Particularly, I had a lot of discussions, so I was a bit stuck, I think, in terms of what operation that I had to choose. I had to choose and come back to the medical panel on. And then, of course, any other surgery or any other treatment that I was undergoing. And the second part, of course, is communicating genetics to my family, risk for my children, and just I'm trying to find out where it came from. And then my mom got tested, and we realized it was from my dad's side. So after all the searching, I thought, if I went through all the process trying to find this, trying to find more, I'm sure many other men and women would be doing the same. Hence now the idea that Marc and I had to set up the session for everyone. So it's a long-weighted road why we set this up, but I hope it will be useful for everyone. And I'm delighted to be able to have the panel here of our top genetic specialists in the UK. So objectives of the session would be several-fold. Is one, to talk about what is PALB2 gene, give you some basic information that Marc will do, and research on the cancer risks. Then we talk about clinical management of PALB2 genetic mutation. And the third one will be family care, how to talk to your family with information that's available, and also provide a forum for you to ask questions. And I will come back to how we do the questions a bit later. So if we move to the next page, Marc, for the from the agenda side, and I'll introduce the panel in just a few seconds. So we'll have the session about PALB2 itself. Marc will run it for 15 minutes, followed by Anju, who will cover clinical management, also 15 minutes, and family care to follow by 10 minutes. So we'll have 15 minutes to Q&A. I know it's not a lot of time, but if this session will be useful and you would like an additional one, we'll consider to run something similar probably later on, but there will be an opportunity to ask questions offline, I believe. So let me introduce the panel that we have today. So in the poster, you have seen some write-ups of many credentials and expertise that we have of Marc, Anju, and Vishakha today. So first will be Marc Tischkowitz, who is the Professor of Medical Genetics at the University of Cambridge, who also practices at Edinburgh's Hospital. So Marc is our #1 PALB2 expert in the UK and the founding member of the PALB2 Interest Group, i.e. it's a consortium of PALB2 experts around the world who meet up on a regular basis. I think it's once a year, but continuously communicate and run global surveys. So Marc is the one who knows everything about PALB2. We have Anju Kulkarni, who is a consultant clinical geneticist and lead for the Cancer Genetics Service at Guy's and St. Thomas's Foundation Trust. She runs multidisciplinary clinics for BRCA1 and 2 and also PALB2. She's a council member of the UK Cancer Genetics Group and medical advisor to the UK Genetic Counselling Registration Board. And we have Dr. Vishakha Tripathi, who is a consultant genetic counselor also at Guy's and St. Thomas's Foundation Trust, who leads HPOC clinic at Guy's that I mentioned, is Hereditary Breast and Ovarian Cancer Service. She has been the chair of the Genetic Counselor Registration Board and a member of the Clinical Genetics Clinical Reference Group for NHS England. Hopefully I pronounce it all okay. So many things that our expert panel is involved in. So if you move to the ground rules just for the call, making sure it's effective and for everyone, mark as the next page. So this event is aimed at the UK community. There was a debate, shall we make it global? But we thought because some of the clinical management guidelines are for the UK, not to confuse our counterparts in other countries. We'll keep it to UK only for this stage, but I'm sure basic information will be useful for them, and I'll mention how we share it. So please respect the views and choices of others, and also be private and confidential here. So this event is also for age 16 plus and for families and PALB2 carriers. The panel will provide as much information as we can and provide guidance, but if you have some specific clinical cases that you would like to discuss, my advice is you discuss it with your medical team, and if you're stuck on any questions, we can always try to help here. So this is not a clinical genetic appointment for your personal case, but I'm hoping that we can cover as many questions that you might have. And thank you to those who provided me with your questions in advance of the event through a Facebook group page. So in terms of Q&As, may I suggest that we're going to run the session, all three presentations in tandem, without Q&As, and we'll leave Q&As to the end. And if you could kindly listen in as you're participating, and then use the chat in the Zoom to post your questions, and I'll do my best to bring them up for the panel towards the end. The main presentation will be recorded, so that's the first 40 minutes, and then we'll post it on the PALB2 Interest Group. So those of your family members or friends who would like to know more, to hear the same, they can access it in a couple of days or so from the website. So we'll try, as I mentioned, answer everything, but if we need more sessions like this, we'll consider putting them out in the future. So I think, have I covered everything, Anju, Marc, Vishakha? I think so. Shall we move to Marc now to talk about PALB2?
Great, thank you very much, Yulia. That was a fantastic introduction. You covered everything and nicely set the ground for this presentation and for the subsequent presentations. And thank you ever so much for organising this. I think it's going to be a great hour, and I hope everyone who's on the call today will benefit from it. So I'm based in Cambridge, as Yulia mentioned, and I'm really going to talk to you today about just the basics. So we're going to go right back to start at the beginning, and I'm going to talk to you about some simple or some questions that I think come up often. So first of all, we're going to talk about what is PALB2, what is a mutation, how common are these mutations? I have a PALB2 mutation. What are my risks? I have a variant of insignificance. Should I be worried? And how can I? And how? Finally, we'll finish by talking a bit about the research and how you can help if you're interested. So what is PALB2? Well, it's a gene. So this means that it's a chemical instruction, and we have 2 copies of every gene in our body. And normally when these genes work, they're actually protecting us against cancer. But if you get a mistake in one copy of that gene, you lose some of that protection. And for PALB2, you lose protection, particularly against breast cancer. So a gene is made out of DNA, lots of letters, and a mutation is a bit like a spelling mistake, essentially. And we have over 20,000 genes, and they're all bundled together in chromosomes in the cell. And we have trillions of cells. So each cell will carry a copy of this gene, but it's only the cells in certain parts of the body, like the breast, that seem to be affected when the gene's not working properly. So what is a mutation? Well, firstly, there are different terms for this. So you may also hear the term alteration or gene change or variant or variation. Mutation is actually falling out of favor, but I've used it today because most people still understand what it means. But a lot of people in the medical world or in the scientific world will now talk about variants rather than mutations. And as I said, a PALB2 is a gene, and a gene is a bit like a sentence in a book. And chromosomes are a bit like the books themselves. And you can take a sentence like this, the car was red, and it's deliberately written in 3-letter words because that's how the genes are read, in 3 letters like this. And you can see that you can get all sorts of different things that can happen. So you can get an extra copy of the letter red. You can get an extra letter put in, which then doesn't make sense. You can lose some letters. Again, here, this doesn't make sense. You don't know what was read, or this here. Sometimes you get a change from one DNA letter to another, which can completely change the meaning of a sentence. And sometimes the sentence stops early. You get an extra punctuation mark. So these are all different types of mutations that you can see in a cell. And you can see the common issue here is that all of them will stop this sentence making sense. And if a sentence is the instruction for the cell to make the protein that actually works to protect against the breast cancer, you can see why there might be a problem here. So the question is, do all cancers arise from genetic mutations? And actually the answer to this is yes, indeed they do. All cancer is ultimately due to a genetic mutation. But we have to distinguish between mutations that are inherited and mutations that actually just develop within the cancer and are limited to the cancer. So the body is always copying DNA to make new cells all the time. Our cells are reproducing, and billions of letters of DNA are being copied out while we're awake, while we're asleep, all the time, while we're alive. And sporadic mutations, which are ones that occur after conception, after we're born, after we've been conceived, they're very common. So they occur throughout our lifetime, that the DNA mutates, and the cells in the body are constantly trying to repair these. And this is, most cancers in the general population are sporadic. Okay, so if you start off with a cell, the cell has to divide, and eventually you'll get one mutation in that cell. And then it carries on, and eventually you'll get a second mutation. And this will take, this first bit here could take 40 years, and this could take another 20 years. And that's why most cancers occur later on in life. So 2/3 of all cancers in the general population occur after 65. Now, with a hereditary mutation, like in PALB2, this is one copy of the gene is already mutated, either in the sperm or the egg. And so when they come together, there's already a mutation there in the cell, and therefore the time frame to the next mutation is shorter. That could just be a period of 20, 30, or 40 years. And then that's when you'll develop cancer. And that's why women who have PALB2 mutations will develop cancer at a younger age than the general population. The inheritance of PALB2 it's called dominant, and this means that essentially there's a 50-50 chance of passing on the mutation to every child. So the mutation can be carried either by the mother or the father, and if either parent carries it, there'll be a 50-50 chance to pass it on to each child, whether they're a daughter or a son. So it's completely irrespective of the sex of the child or whether they have other characteristics that are similar to the parent, it's a random event, and it's 50-50 every time. So if you have 4 children, you could have all 4 affected, 3 of them, 2 of them, 1 of them. It doesn't follow any rules. It's like tossing a coin, essentially. How common are PALB2 mutations? Well, we estimate, we have some reasonably good data now, and we think about 1 in 700 people in the UK carry a mutation in one copy of their PALB2 gene. That equates, if you take a population of 60 million, that equates to 85,000 people in the UK. And then you can further split that up to the over 30s, which would be about 56,000 individuals or 28,000 women. So that means that there's about 28,000 women in the UK, we think, who are PALB2 carriers. The vast majority of those have no idea about that. And they may come from families with very little family history, and they may actually never develop any cancer, and it may never come to light. Some of them will develop breast cancer at some stage and be tested, and then the gene mutation will be identified. And a few of them come from known families that we already know about. And we only know about very few of these. So to give you an example, in the East Anglia region where I work, I think we've estimated we have about 70 PALB2 carriers that we know about. But actually, going by these figures, there should be about 1,500 in our region. So you can see there's a lot of work to be done still. And I think one of the reasons for that is that testing for PALB2 hasn't been around for very long. We've only really been doing it on the NHS since about 2015. So most PALB2 mutations are family specific or just shared by a very few numbers of people. There are a few common ones. So for example, this one here is quite common in the UK, this mutation. So several people on this call for example, might have this particular mutation. And that probably means that they share some common ancestry going back a long way. This one here is actually a Finnish one, because this is a representation of all the genes internationally that we saw. So this is a mutation that's particularly common in Finland. So that's why that's peaked. But you can see most of the time that all the mutations spread throughout the gene, quite evenly throughout the gene, and fairly, not many individuals have a particular mutation. So the next question is, I have a PALB2 mutation, what are my risks? So the gene itself was discovered in 2007. It's linked with breast cancer, but it took us 7 years to get to really understand what the risks were. And this was the first paper that we published as an international group, the PALB2 Interest Group. And that was on 154 families, published in 2014. That was really a landmark paper because it really established the breast cancer risk quite well. More recently, this is basically the same team of people, but we've got more collaborators now. Again, throughout the world, there are 44 centers throughout the world that contributed to this. We now have 524 families. And for this paper, because we had more data, we were able to look at some of the less common cancers like ovarian cancer and pancreatic cancer. So here's a graph of what we found in our latest paper. And essentially, so the age is along the bottom here, up to age 80, and the risk is up to about 60% here along the side. And this is the curve to look at. So you can see, and this is the curve for the general population here. So you can see that the risk to age 50 is about 17% for breast cancer, and it goes up to about 55%. This is the average risk, up to about 80. Now, these figures here are the confidence intervals, and that means that we're 95% sure that we're saying this is the figure, but there's a range of error, and we're 95% sure that the figure lies somewhere between this range, essentially. So the narrower this range, the more sure we are that we are in the about the figure that we're using. And you can see that the figures are the figures are fairly. I mean, that's not a bad range actually. For many breast cancer genes, it would be wider than that. What we also found was that there was a link between the risk and the family and the family history. So here, if we look at the blue line first, that is just an average PALB2 mutation carrier here, the blue line. Now, if that person also had a mother affected with breast cancer at 50 and a grandmother affected with breast cancer at 50, their risk would be quite a lot higher than the average PALB2 carrier. You can see the difference there. And if their mother had breast cancer at 35, it's a very similar risk. And here, with an even stronger family history of a mother with breast cancer at 50 and a sister with breast cancer at 50, the risk is even higher. So the risk of a person is proportional to their family history. Moving on to ovarian cancer. So this is the data from the latest paper, and this has been quite hard to pin down. And you can see, first of all, notice the scale here is quite different. So we're only going up to 10% risk here, and the bottom scale is the same, up to 80. And again, this is the green line is general population, the orange line or the red line here, the thick red line is the average risk. And we can get up to about 5% average risk by age 80 for ovarian cancer. You can see the risk below the age of 50 is very small indeed. So we're well below 1%. And also you notice that actually the range here, the confidence interval for us is wider. And that's because there are many fewer cases of ovarian cancer, and we're a bit less certain about this risk. And since this paper's come out, there's another paper that has estimated the risk at about 3%. So that's within the range of estimate that we've put it at. So we're fairly sure that the risk does lie somewhere around here. It's certainly not going to be higher than this. Because we're worried, I think these risks are going to be at the highest end, and anything that gets published subsequently is likely to become lower than this. So I think we can say that this is, about right. And actually that reflects what I've seen personally when I've looked at hundreds of family trees of PALB2 carriers, and it's not very common that you see an ovarian cancer in a PALB2 family. We've also looked at some other cancers that we know have been linked with PALB2. And again, look at the scale here. So now the scale is even smaller here. So we're only going up to 6% now, lifetime risk. We've got pancreatic cancer for females, males, and male breast cancer. And again, you've got the average, you've got the same principle here, the population level here in green, and then the red line for the average risk. And you can see for pancreatic cancer, the average risk is probably just over 2%, a little bit higher for males there. But again, reasonably wide margins of error around those figures. And then for male breast cancer, the risk looks like it's less than or around about 1% to age 80. So pretty small risk. But again, because we had very few cases of male breast cancer, we're less sure about the confidence here. Although again, it's not going to be very much higher than that. So those are the risk figures for the main cancers that we know are linked with PALB2. We did look at other things like bowel cancer and prostate cancer, and we did not find any associations. So I think for as far as we know at the moment, the risk really is confined mainly to breast cancer, with some smaller increased risk for ovarian cancer, pancreatic cancer, and male breast cancer. Next question. I have a variant of uncertain significance. Should I be worried? So I get this question a lot. A lot of people contact me about this. And I've just put in the slide that we showed you before about the mutations. So a variant of uncertain significance is slightly different to this. So again, using the same sentence, I've changed the letter C to a letter K. Okay. So the sentence structure is still the same. If you read this out to someone over the phone, it would make sense, whether you said that sentence or that sentence. So this may just be a normal variation. If you saw it written down, you may understand what it means. It may just be a normal variation, or potentially it could cause an error. We're not quite sure. Most of these, over time, based on our experience, will turn out to be normal variation. And a lot of our time and effort is spent on getting more data to better understand these variations. And this is basically a problem that is getting much better over time. And the more we learn about these genes, the more of these we change. A few of them will become true mutations, but most of them will become normal variations. And so I think in general, we do not use these for any clinical management. And I think that's the bottom line. So you would not want to do any preventative surgery, for example, based on this. And you wouldn't really want to do surveillance based on this either. You'd want to do it based on your family history. We do keep these under review. And the time frame in genetics is fairly long. So I would say, if we reviewed this every 3 to 5 years, there'd be new data, and we could then reinterpret these variations as more and more knowledge is known about the gene. But in general, one shouldn't be worried about this. One should just be aware that this is the situation, and that things may change in the future. But they're more likely to change to normal variation than to a mutation. Finally, how can I help with PALB2 research? Well, as Yulia mentioned, there is an international group, and we meet once a year. And this was our last meeting last year in San Diego. It's an international meeting of clinicians and scientists from throughout the world. This year we're not having a meeting for obvious reasons, and we may have a virtual one later on in the year, but hopefully this will be reinstated next year. In the UK, so there's a website which is relates to all the activity of this group, and there's information there for health professionals and also for members of the public. In the UK in particular, there's been a new development because what we are doing is switching our data collection to the EMBRACE study. Now, many of you will have already signed consent forms and helped us, and your families will have been part of those, at least, maybe one or both of those papers that I showed you before. So this is how we use your data to benefit to bring that back to the community. And but a lot of that data is based on what's happened in the past, and it's subject to biases. So what we're doing now is teaming up with the EMBRACE study to actually to track women and men who are PALB2 carriers going forward to see what happens to them over time. And that way you get rid of a lot of the biases in these sorts of studies, so you'll get better, more accurate data, but it does take longer to do. If you have any questions, or if you're on this call today and would like to be kept informed about things, please do contact us through this email address here, and we will keep you on a list of people that are happy to help us with research. And at that point, I will finish and hand over to Anju.
Thanks a lot, Mark. That was a good overview and brings us on to really clinical management of PALB2 gene mutation carriers. So over the sort of next 10-15 minutes, I'll just give you a whistle-stop overview. If you could go to the next slide, please, Mark. Thanks. So as Mark's really gone over in a nice detail, the main risks that I'll be covering are risks of breast cancer for men and women, and ovarian cancer risk and pancreatic cancer risk. And I'll be covering surveillance, surgical risk reduction, chemoprevention, and also talking a little bit about new targeted therapies. I'll touch on reproductive options as well, and also mention lifestyle and symptom awareness in the general population as well. You carry on, Mark. So firstly, thinking about breast cancer. So as Mark's already mentioned, the predominant risk is for women and breast cancer risk. And in terms of surveillance, the aim of surveillance really is to detect, diagnose and treat cancers when they're small, less aggressive, and there is less risk that they have spread. So ultimately it's about detecting early disease or pre-cancerous disease as opposed to preventing a cancer, and that's an important distinction to make. So at present, the women who do have a PALB2 gene mutation can be referred into the NHS for high-risk breast screening, and there has been some updated guidance that has literally started in September of this year, so just very, very recently published, that actually highlights that individuals with more than a 40% lifetime risk of breast cancer would be eligible for increased screening, early breast screening. Now that screening would be annual breast MRIs from 30 years of age up to 50 years of age, and then annual mammography added in from 40 years of age onwards. This referral into the very high risk breast screening program needs to be done by a genetics clinician at present, and that's because we need to calculate an individual's risk of developing breast cancer based on the fact that they carry the mutation, but also, as Mark's already mentioned, family history does play a role in determining what risks there might be for individuals. So we use a tool called Bodicea or CanRisk most of the time, and this is a tool that's been developed by Mark and his colleagues in Addenbrooke's and in Cambridge. And using that tool, we can calculate not only lifetime risks of breast cancer for women, but also 10-year risks. And in the new guidance, we know that women with more than a 8% risk, 10-year risk, are also eligible now for MRI scans starting from 25 years of age, rather than 30 years of age. Could I have the next slide, please, Mark? Just to mention, sorry, in terms of surveillance and male breast cancer, as you saw, the risks of a male breast cancer are relatively small. And at present, there isn't really routine surveillance that we can offer for male breast cancer. So we recommend that men have symptom awareness, and they seek advice and have a low threshold for seeking advice if they have any unusual lumps, either on the chest wall or under the arms or around the neck region. So the other option for risk reduction for breast cancer for women is risk-reducing mastectomy. Now, this nice guidance at present, the National Institute for Clinical Excellence in Healthcare, is that we should be offering risk-reducing mastectomy to any individual who has more than a 30% lifetime risk of breast cancer. Now, at Guy's, in our HPOC family service, we offer this surgery from 25 years of age for women who carry a PALB2 gene mutation. But it's really important that there's multidisciplinary input into the decision-making process for women to help support them through this decision-making. We have a team of breast surgeons, oncoplastic surgeons, together with us as geneticists, oncologists, clinical psychologists, and clinical nurse specialists. And individuals can come to the clinic and meet with these different members of the team to gather information and find out more about what their options might be in terms of the surgery and risk reduction as well. We know that mastectomy can reduce breast cancer risk by more than 95%. And as I mentioned, this contrasts with surveillance, in where we are reducing the breast cancer risk and preventing breast cancers from developing, as opposed to surveillance, which is about early detection of disease. Occasionally, we do find hidden malignancies or cancers at this time of surgery, and that is something that women are counselled about at the point that they consent for the surgery. But it's important to bear in mind that still at this present time, we don't really have clear data to show a benefit of risk-reducing mastectomy compared with annual breast surveillance for PALB2 carriers. And as Marc has mentioned, more research in this area will give us those answers as we go forward. So when faced with this decision about which option to choose, there are many factors to consider and to take into account for women. What is their current age? What are their family plans for whether they want to have children? Have they completed their families? Would they want to breastfeed their children? Also importantly, whether they have a personal history of cancer, and if so, what was their age at diagnosis? What was the tumour histology and stage? And importantly, what kind of treatment they would have had for that breast cancer, whether it's previous treatment or their current cancer treatment. It's important that we take into account prognosis from previous cancers and the risk of recurrence, and compare those competing risks for women so that we're making the right decision for that individual. Some women have other medical conditions that may prevent them from having mastectomy, or may make it more likely that they'll have complications. And as I've already mentioned, and as Marc's mentioned, family history of cancer plays an important part in helping to determine risk for women, and therefore determine whether surveillance or surgery might be more appropriate for them. Importantly, a person's personal perception of risk is really important, and is something we spend quite a bit of time exploring with women. And if you could move to the next slide, Marc, just to highlight that this is a really important aspect, because we don't have real data yet to show that surgery is better than surveillance. It's important that we take into account a woman's personal risk perception, which is influenced by many different factors, things like their own personal history of cancer and other medical conditions, but often their experience of cancer in the family really will drive decision-making to a degree as well, particularly if they've seen many bereavements or young cancer diagnoses in the family. An individual's personality type, the age and stage they're at in their life, and their future plans are all of the things that we would explore with women through that decision-making process. And it's important to also bear in mind that recent triggers can also influence whether someone opts for surgery or surveillance, so things such as a bereavement, pregnancy, or marriage. So the other option in terms of reducing breast cancer risk is what's called chemoprevention, which isn't a great word because it's not really chemotherapy at all, but it's the use of substances to stop cancer from developing. And it's important to bear in mind that even if a person uses a chemopreventive drug, they could still develop cancer in the future. So it doesn't prevent it completely, it just reduces that risk for individuals. Now, chemoprevention works by blocking the action of estrogen in the body, so its impact is greatest in preventing the estrogen-driven breast cancers. And PALB2 mutation carriers are at risk of both estrogen-driven and estrogen-negative breast cancers. So it's important to bear in mind that chemoprevention wouldn't necessarily have a particular effect on reducing the risk of the estrogen-negative breast cancers. Now, the effectiveness of chemoprevention really depends upon an individual's risk and also how long they will adhere to the treatment, because we know that most of the studies have looked at chemoprevention for the risk reduction effects to take place. They need to be taken for a period of 5 years. So again, NICE clinical guidelines recommend considering tamoxifen and raloxifene, which are 2 chemopreventive drugs, for women at high risk. And so they can be considered for women who have a PALB2 mutation. Tamoxifen tends to be used for both premenopausal women and postmenopausal women, whereas raloxifene tends to be reserved for postmenopausal women for whom tamoxifen may not be appropriate because of complications or side effects or contraindications. But as I've mentioned, and as is a sort of recurring theme, unfortunately, we don't have a lot of data on the use of tamoxifen and raloxifene in PALB2 gene mutation carriers, and much of the guidance is really extrapolated from women with a familial risk of breast cancer in general. So moving on to ovarian cancer. Now, ovarian cancer, women often ask, is there any surveillance? As Marc's already alluded to and mentioned, the risk actually isn't as high as we were worried about initially. And at present, in terms of surveillance for ovarian cancer, we don't have very good screening tools. The current tools that are used are pelvic ultrasounds and blood CA125 tumour marker measurements, but these don't really detect disease at an early enough stage at the moment to influence outcome. Now, one hypothesis is that because the majority of ovarian cancers may arise from the fallopian tubes rather than from the ovaries themselves, we might miss them on a scan, or they might not be producing the CA125 tumour markers in the early stages. So there's a risk that with surveillance, really, that we're going to be providing false reassurance to women if the tests are normal, and as a result, they may not then go on to seek advice if they have symptoms early enough. And so at present, there's not really any evidence to support this kind of surveillance for PALB2 carriers. So the other option is risk-reducing removal of the ovaries and tubes, but we do have a threshold in terms of ovarian cancer risk for offering this surgery in the UK, and that threshold at the moment is at 10% or greater lifetime risk. And as Marc's already mentioned, the lifetime risk for PALB2 women is 4 to 5% or 3 to 5%, depending on which literature you look at. So it is below that risk threshold that we would use to offer this sort of surgery, but it can be undertaken at a lower risk threshold for some women. Sometimes women may need that surgery for medical reasons unrelated to the cancer risk. For some women, it might be part of a treatment plan if they've had a hormonally driven breast cancer. And also there are some families where there is a significant family history of ovarian cancer in close relatives that may not be entirely explained by the PALB2 mutation, and it may be appropriate to consider this surgery in those women. Ultimately, this sort of surgery results in an early surgical menopause, and that's really the importance of why we don't offer it routinely. We need to balance the long-term complications of an early surgical menopause with a woman's risk of ovarian cancer, and make sure that we're not doing more harm than good by performing this surgery. Estrogen is important for us as women in terms of protecting our bone health, our heart health, and our brain health. So it is important that we maintain the quality of life for women and prevent those long-term complications as well. So pancreatic cancer surveillance, both for men and women, as Marc's mentioned, is around a 2 to 3% lifetime risk for PALB2 carriers, and it's a contentious issue in an area of ongoing research, really. NICE guidance was published in 2018, which suggested that we should consider annual MRI surveillance for PALB2 carriers, but there hasn't really been robust data to demonstrate a benefit on long-term outcome with this sort of surveillance. And for pancreatic cancer, there is a risk of what we call false positive results. So this is screening where we detect something that isn't a cancer, but results in more investigations and biopsies, and the resulting complications that can ensue from that. And biopsying the pancreas can result in pancreatitis, so a life-threatening complication. So it's not without its risks in terms of the interventions that might happen as a result of a false positive screen. So this has been debated nationally, and the UK Cancer Genetics Group, for which Marc is the chair, currently recommends that we should be offering surveillance for pancreatic cancer through research studies like the EuroPac study, which we invite all our PALB2 carriers to participate in. I'd advise that if you are concerned about this risk, then it's important to discuss risks and benefits with a specialist who's familiar with the literature. So moving on to cancer treatment, it's a very long title there, but what I'm referring to is a DNA repair pathway. So Marc had mentioned in his talk about how these genes are very important, and the PALB2 gene is very important in repairing our DNA. And our DNA is damaged all the time by external factors throughout our life. Now, genes like BRCA1, BRCA2, and PALB2 play a key role in a form of DNA repair called HR DNA repair, or homologous recombination DNA repair. Now, what we know is that cancers that are caused by PALB2 mutations aren't able to repair their DNA using this pathway because it's not working properly. Now, that's why people can develop cancer at a younger age, but it's also something that we can use in a positive way to target that Achilles heel of the cancer. And we can target that Achilles heel using chemotherapy or new targeted drug treatments. So at the moment, there are clinical trials of platinum-based chemotherapy and what we call PARP inhibitors in individuals who have PALB2-associated cancers. And there have been lots of studies that are ongoing looking at these PARP inhibitors in both breast cancer, ovarian cancers, pancreatic cancers in general, but for PALB2, predominantly the breast cancers. And we're learning more and more about how we can test cancers to guide treatment options, and it's a huge evolving area of genomic testing, looking for those mutations that Marc talked about that drive cancer growth. And by finding those mutations, we can help guide treatment options and clinical trial eligibility for some patients. What we can also do is take samples not only from the cancer itself, but look at blood samples where the DNA from the cancer has been released into the bloodstream, what we call circulating tumor DNA. Now, this is a relatively new technology that's been identified in the last few years, but it is, and it's at the present really used in the treatment of people who already have cancers. But there is a possibility of using this sort of technology in the future, perhaps to detect early cancers, but more research is needed really in this field. The other thing to bear in mind is that sometimes inherited PALB2 mutations can actually be identified by these tests that are performed on the cancer and the circulating tumor DNA results. So as Marc mentioned, we haven't identified by any stretch of the imagination all the individuals who carry PALB2 mutations, but it may be that through the route of tumor testing in the future, we do identify more and more individuals who carry these mutations. So what reproductive options are there? Couples do come to us in the HBOX service and ask, you know, how can I prevent passing this mutation on to future generations? And there is a technique that we offer called pre-implantation genetic diagnosis. It's not a technique that all individuals would want to pursue or consider. And again, it's a very personal decision based on people's experiences and personal experiences and family experiences as to whether they would want to explore this. But basically in this situation, couples undergo IVF treatment and the embryos are screened to see if they carry the familial PALB2 mutation. And embryos that do not carry the mutation are put back in the womb for implantation. Now, this whole process is governed nationally by the Human Embryology and Fertilisation Authority. And Guy's Hospital is one of the main UK centres at the moment and one of the main centres in Europe offering PGD. There is a specific NHS funding process which can take up to a year or more. And at present, only couples who don't have children are eligible for funding on the NHS for PGD. If it is something that you're interested in or would like to find out more about, then our PGD service is open to referrals from across the country. So finally, just to mention lifestyle and symptom awareness, which is not last on my list because it's not important, but it is something that we, again, probably don't have a huge amount of data specific to PALB2 for at present. We know that there are lifestyle factors that affect a woman's risk of breast cancer in the general population. So estrogen exposure, so hormone replacement therapy or oral contraceptive pill can influence risk. We know that pregnancies and breastfeeding are protective for breast cancer risk. And we know that diet, weight, and exercise all influence risk. In particular, weight gain can certainly increase a woman's risk of breast cancer. And then, of course, you may have read that excess alcohol consumption and radiation exposure are also risk factors to consider. It's important that women remain self-aware and have a low threshold for seeking advice if they have symptoms, and the same for men as well, in terms of, even though the risk of breast cancer is low, if they do notice any unusual lumps, that they have a low threshold. It's also important that your GP is aware that you carry a PALB2 mutation, and being part of a multidisciplinary service like the HBOC service can make sure that that link with your GP is robust as well. So just to summarise, there have been huge advances in the management of PALB2 carriers in the last decade. I hope I've shown that multidisciplinary care through services like the HBOC family service is important to help management support for families and access to new clinical developments. There are novel treatment options and technologies for early cancer detection on the horizon, but these do require more research. And as Marc has mentioned, and with his team and international researchers, there is a growing body of literature clarifying these risks. And hopefully we will be able to translate this knowledge into personalised risk stratification, cancer prevention, and tailored treatment for PALB2 carriers. Thanks. So I will pass on to Vishakha now, who I think is going to talk to you about family care and communication in families.
Thank you. Hello, everyone. A real shift now, so no data, surprise, surprise from me. We're all talking about families here. So I'm a consultant genetic counselor working with Anju at Guy's. Thank you for giving us time today. Marc, could you move to the next slide? Thank you. And I'm hoping to give you a glimpse of some of the issues encountered in sharing risk information, which I'm sure you will all be familiar with. I'm drawing from a little bit of the literature and the experience of others, and getting you to think about what might fit with your family, and getting you to reflect on some of the strategies that you might want to use to facilitate some of these conversations. Next slide, Marc, thank you. So I'm sure all of you have had discussions at different levels within your families after you've had genetic testing, and are well versed with some of the challenges that this can bring. Most of the data, however, to date is still derived from families who carry BRCA mutations. Having said that, I don't think the issues are dissimilar. So although specific PALB2 related communication challenges and the sharing of risk information remains unexplored, I think we can potentially use some of the lessons that we've learned from the other families with other mutations. By and large, studies have found that there is this concept of psychosocial hardiness amongst relatives, particularly children, adolescents, and then as they grow up and become young adults, who are told about the mutation information early on. They seem to adjust quite well to this. Having said that, no one has actually looked at how long this psychosocial hardiness lasts. Does it change as they become adults? Does it evolve as they begin to have these conversations with their own children? And I think that's quite a fascinating area. If you look at how a person reacts once they've had their own genetic testing, so if you've got children above the age of 18, they would be eligible to access genetic counselling and predictive testing through their local genetic services. We know that there is evidence to suggest that if there is ongoing treatment in a parent or a sibling, whilst they undergo their own genetic counselling and testing process, often their reaction once they receive their own result can be clouded by the ongoing diagnosis, management and treatment of a family member. This can often result in somewhat a stunted reaction post-testing, and that's quite well known. It's really useful for us as genetic counsellors to know this, because these are some of the issues that we explore with people whilst they're making their decisions about testing and thinking about when it might be the right time for them to pursue it. We also know that having information affects our sense of control as human beings, regardless of whether we're talking about PALB2 or any other health and disease-related issue. In terms of men, so Marc and Anju clearly outlined beautifully the risks for women, but also the data suggests that men are not going to be affected with those risks in a similar way. What this means is that if you have intervening men who have daughters or have inherited the familial mutation from a mother, their risk perception might be different, or their timing of accessing testing also might be different to perhaps a younger woman. And there is evidence to suggest from other families, obviously not just in PALB2, that this can sometimes delay the process of risk communication within a family. So that's just something to be mindful of when navigating some of those conversations within your own families. Next slide, please, Marc. Thank you. So the next thing I want to move on to is really looking at this concept of family scripts. And a family script really is each family's shared expectations of how family roles are performed in various contexts. And Baynham and Hall have done a lot of work in this. We use it in genetic counselling quite a lot, because you can identify actually what your own family script might be and what you have used in the past to share information, not necessarily related to PALB2 mutations, but actually how do you communicate within your families when there is new information to be shared? When do you do it? Who is responsible for that, and how do you decide who is responsible for sharing it? Literature suggests that the early identification of a family script can really help us in identifying how to navigate some of the challenges and barriers. So potentially, if you know that there is someone that usually tends to avoid information, then actually you know that that's their script, or you may know someone that likes to have information told to them in a particular way, in a particular setting. Again, you can use that to your advantage in this context. We know it allows for increased adjustment, coping, but also open communication. So thinking about what the norm is in your families, how it's helped you to share the information in the past might be helpful. And what would you or could you and like to do to change the scripts that haven't worked for you in the past when information has been shared might also be helpful in making things more constructive in the future. In terms of resources, so I know that in the PALB2 context, a lot of you contact us because the information and support avenues are still evolving. I would highly recommend that you remain in contact with your local genetic services. The role of genetic counsellors is not only to provide information, but also psychosocial support. And this becomes particularly relevant in the post-testing phase, so please do contact them. Some genetic services might have access to psychologists and family therapists, or your GP might be able to refer you to a psychologist that is more familiar with family therapy techniques. The use of letters and leaflets, we certainly, all genetic centres do send you letters which you can use to share this information with relatives. This enables them to access their GPs and get a referral to their local genetic services if they would like more information or to consider testing. There's also the development of some web-based information sharing platforms in the research setting, and certainly in the future, one hopes that there might be some really fancy platforms that people can access and share their mutation reports, for example, so that your auntie or your cousin living abroad can have that information without you having to scan it and attach it to an email all the time. So please seek support from your healthcare professionals. They are very familiar with the issues that you might be encountering, and there might be some local support groups that you might find helpful. They might not necessarily be focused on PALB2, but you might find sharing your experience and hearing others that may be at increased risk helpful in making some of your own decisions and choices. Thank you.
Great, thank you so much, Vishakha, Anju, and Marc. Very, very informative. Just looking through chats, a lot of a lot of thank yous and excellent feedback. I think we're going to stop recording now, and we'll move to Q&As just to make sure that the information that's been shared is, if it's sensitive, it's not being recorded here. Just